All right, good afternoon, everyone. So thank you, Lee, for that phenomenal introduction. Welcome to, this is my third town hall meeting. Last year went great. I'm expecting the same this year. So remember, we're all on the same side. So when we get to the Q&A task time, be kind, but we're here to listen. We're here to listen. Today, I hope to get you to that Q&A session as quickly as possible. So we're going to give you a bunch of information, but really what's really important is to get your feedback so that we know where to go, what to work on, and get some goals for us to work on for the next town hall. So the panel, I don't come alone. I bring the people who do all the work, right? So John Lackrose, our chair for the Commission on Credentialing. Julie Daggum is our director for Residency Accreditation. Eric Grace, our director for Standards Development and Training. Amy Haida-Cardillo is our director of Operations. Lisa Lifshin, senior director for Pharmacy Technician Accreditation and Residency Accreditation Services. And Andrea Roberson, Director of Process and Quality Improvement. So none of this, everything that you're going to hear today could not be possible without this phenomenal team. So, a little round of applause for our phenomenal team at ASO. The other thing we could not do this without is our COC members and our lead surveyors. So they're all up here, up in front. Make a little wave to the crowd, everyone. So our surveyors and our COC team are here. We may call on them if you stump us with the question. Maybe they can help us out along the way. But again, thank you for all your hard work to make sure that we're maintaining those standards and having a quality work environment for our residents. So just giving you a little, syllabus, if you will, of what we're going to do today. I'm going to talk a little bit about residency growth and the match. I'm going to slim those slides down. I already did slim those slides down, so we're not going to go in depth in the match, but I'm going to show you where you can if you're interested in learning more numbers, if you're the numbers people. We're going to hear from John, and he's going to give you some introductions of our COC members and the new COC members. He's going to talk to you about the actions that we've taken in the last year, some updates and accomplishments. And then Julie's going to come up and talk to you about some of the highlights from 2024. So if you remember, I take some of the things that you ask us to do, and we give you some feedback or ideas of what we have accomplished for you for this year. She's then going to talk about survey transformation and our continuous process improvements. And then this is her 2 cents, hot topics, did you know? That's the Julie 2 cents. And then we're gonna open it up to that Q&A. That's the fun time, right? When we're all friends still, but we're gonna get questions and answers. So let's talk about growth in the match. We continue to move that graph up and to the right? So if you remember last year, we celebrated 3,000 programs. We're now at 3,100 programs, and you could see the increase in PGY1 and PGY2 programs across the country. So Amy has been handling a ton of applications. We were very excited about that last year. So we continue to grow the number of programs. Now I know anecdotally we always hear applications are down. We continue to track this, that line that runs through there, that's the percentage of applicants based on the number of graduates. We continue to maintain that 40%, 40 to 50%. We're at 47% in 2025. So then that is the number of graduates that we see applications for in residency programs. While the numbers are down, it's because N is down, right? The number of graduates down, so that also is down. I will tell you that the number of applications per applicant has been also down. So in previous years, we've seen applicants put in 12 to 14 applications. They're doing about 8 to 9 per applicant. So they're being more selective in how they're applying. However, that does overall impact that number of applications that are in the system. So if we look at some of these numbers, you can see a couple things, that the total number of positions between 2024 and 2025 have increased. So in 2024, 5,896. In 2025, 5,962. And you can see under those the breakouts of PGY1 and PGY2. You also can see the number of early commits continue to rise. We're at 703 in 2025. If you remember, that was one of the things we did, was open that up to the health system. So it doesn't have to be in the single hospital. If you're within the health system, you can early commit any of those residents into your PGY2 programs, depending on the policy or rules that you have within your organization. It is up to you to decide how to handle that. If you look at the number of applicants, you can see that the number did go down. If you look at total, 6,009, as opposed to 5,973 in 2025, but that early commit number went up. So you can see it's pretty flat. Total number of applications was 6,676 versus 6,673 in 2025. So again, anecdotally, you're going to hear the applications are going down. I'm just giving you the numbers to show you that we're pretty consistent from the previous year. And we've so far had hit the ground running this year for a number of applications. So those are the numbers. You can see it was much slimmer than we've done in the past. But aggregate statistics are on the NMS match site. And I gave you the link here, but if you just Google NMS ASHP match stats, it will pop up. And on there of previous years, you could see match trends. You could see historical statistics by either applicants, residencies, and programs, or schools. So if you really want to dig into the numbers, you can do that. But for today, I just wanted to save that amount of time because I really want to get to the Q&A to hear from you, which is the most important part of today's session. I don't want to lose this because I know we mention it every year, but we are continuing to follow why residents do not complete programs. And you could see the biggest piece of the pie is that dark blue 230 resident was unable to get licensed in the 120 days. And then the personal reasons is the second biggest part of the pie. We continue to do research. We're partnered with University of Georgia College of Pharmacy, and it's sponsored by ASHP Foundation. So Beth Phillips is here. If, later, if you have some questions, you could corner her. See, you're welcome. Really the purpose is better understand the factors leading to the inability to finish. We really want to dig in because that's all we have. We don't know, is it law? Is it NABP? Is it I didn't get my attestation in time? So we need to understand and dig deeper. There were a couple posters presented at the Futures meeting. You may have seen an article that was published in the Pharmacy Practice News with a title that we decided it was clickbait because it was not really the gist of the article. We did give them a nice little note to change that the title, which they did on the electronic version, but the paper version was already out there. But we didn't have enough information to state what was actually the reason. So we continue to dig. The initial results are out there, but we continue to dig into those and look at additional RPD surveys to get some more results. We want to explore the residents' perspective to try to understand their reasonings for not completing, and then collect data over an entire residency year and see what the outcomes are. So more to come on this. Why are we doing this? We want to try to understand the reasons why, to give you the tools to help residents succeed and continue through their program till the end. With that, I'm going to turn it over to John, who will give you some updates from the COC.
Thank you. Okay, good afternoon, everybody. My name is John Lacro. For those of you who don't know me, I practice out of San Diego, California. And I guess I'll apologize to my colleagues that I missed the memo on wearing blue today. But, hopefully, will excuse me. All of us in the room are involved in residency training, and we clearly know that it takes a village really to do all the work that we need to do for residency training. And in part, what I'd like to do now is ask all of the current COC members to stand, please. So these are kind of a list of really dedicated professionals who work with all of you in the field, residency program directors and preceptors. We're all kind of in the same boat. And we're really just trying to optimize residency training so that we can generate future colleagues will be able to take care of the patients that we work with. So I'd like, if you don't mind, give all of these folks a nice round of applause. Kind of a special recognition to those highlighted in orange, as they will be coming off of the COC this year. Pat, Sandy, Winter, Zach, and Rick. So thank you. And then with those folks who are going off of the COC, obviously they will be replaced with some additional members. These are folks that, if you know them, please congratulate them and welcome them to the COC, but also make note of them if they practice in your area, because they will be well-versed with all of the new things that the CLC will be doing kind of in the near future. So welcome Melissa, Lisa, Aaron, Connie, and Daniela. Now I'd like to transition into some of the stuff that the COC did over 2025. I mean, clearly one of the things that we consider is just kind of the accreditation process. And the two big meetings that we have both in March and August, this is kind of a big component of the meeting. So in both of those years, this slide kind of highlights the number of programs that we considered for initial accreditation, reaccreditation, or for those that had to submit a progress report. We reviewed the progress report and made some decisions regarding the continued accreditation for those programs. So in March, we considered 337 programs, and then in August, we considered about 250 programs. So kind of a lot of programs that come across the COC on an annual basis. Kind of one other key thing that the COC is responsible for is kind of keeping track of the regulations and updating them as necessary. One of the things to kind of go back in time is that in 2024, we kind of revisited the terminology between single and multi-site residencies. There was a lot of confusion behind that. There was a lot of ambiguity, and it was really difficult and challenging for the field to understand that. So we eliminated that. And this is just kind of a friendly reminder to folks that there were a couple of programs that were kind of caught in the middle between single and multiple program sites that by July or the start of the next academic year, they need to be in compliance with the regulations in terms of this terminology. Some of the other updates that we considered in August is that we extended the duration that programs can remain in pre-candidate status. We simplified the duration or clarified more clearly the number of years that a program can be inactive or not have a current resident. We removed kind of outdated requirements, particularly as it relates to things that we asked sites to keep in terms of in paper, if that information is already kept in Pharm Academic. Kind of a list, or submitting a list of the graduates of your program is kind of one example of that. And we clarified the verbiage in terms of PGY2 pediatric specialty programs. We clarified or better defined the withdrawal and reholding process of accreditation when it does occur, and then clarified the appeals process if appropriate. Regarding annual fees, the regulations better aligned with the annual fee schedule. And then lastly is really in kind of a goal to try to make things clearer and simpler for the field, we made some clarifications in kind of the verbiage in the regulations. For the standards, so we also did some work this past year regarding residency standard, accreditation standard. One notable addition is that programs are now required to add the end date on the completion certificate for residents. This is a new addition. Some other things that we did in terms of editing things is that with respect to initial development plans, specifically for Objective 3.3b, we noticed that there were some duplications across several objectives, and so we've simplified that and removed the duplications and made the verbiage or wording better aligned with the electronic resident development plan, which was introduced with this academic year. And then lastly, again, just in terms of just trying to keep things clearer and easier to understand for the field, we've made some changes with respect to guidance in the standard itself. Some of the guidance just made it easier for the field to fully understand what the survey team will be looking for in terms of what would be fully compliant versus something other than fully compliant. Particularly paying special attention to those common areas that programs were commonly cited over the past couple of years. And as Lee mentioned earlier, yes, the COC did approve as a novel type or demonstration type of new residency, veterinary pharmacy residencies. It's a new type. It really took into consideration a report that was generated and delivered to the COC at our recent meeting in August. And really they wanted to review what was ongoing about the feasibility of creating veterinary pharmacy residencies that really are already in place in the country. Tracking at how well it would be implemented or harmonized with our existing standard in our existing PGY-1 harmonized KGOs. Obviously, since veterinary pharmacy is somewhat a little bit different than community-based residencies, managed care residencies, or pharmacy residencies, the task force also came to the table with deliverables specific to veterinary pharmacy and kind of spelled out appendix requirements associated with veterinary pharmacy. And really, because of that great report and work that the task force did, the COC approved it as a novel residency type of program. This slide just kind of highlights the members who were on the task force. It included a lot of program directors in veterinary pharmacy that have existing programs. Just reaching out to ASHP, I guess, and finding the value of perhaps having the stamp of approval from the accreditation process with ASHP. There were members of the Accreditation Services Office as well. And a special thank you to both Michelle and Nicole, who kind of spearheaded the task force for the COC. So thank you for that. One other thing that we highlighted also was we went back and took a look at the PGY-1 harmonized KGOs. With the introduction of veterinary pharmacy, obviously we needed to make some adjustments to that. And for those of you who are familiar with the KGOs, the PGY-1 KGO, it kind of spells out in a separate column the deliverables associated with veterinary pharmacy, and then it created an appendix specific to veterinary pharmacy. This would be similar, very similar, but specific to veterinary pharmacy with what we already have in place for managed care. The other big update that we did regarding the PGY-1 KGOs is we worked on objective R2.1.2, which refers to the project plan, kind of clearly spelling it out for all programs, all different types of PGY-1 programs, kind of the requirements that is expected when you are being surveyed. Also made it clear that while there might be multiple programs that a resident will be assigned or participating in during their residency year, that this requirement really only applies to their major project. We've also started doing some work with kind of the PGY-2 KGOs. Obviously wanting to try to make the process much more efficient. And we really use kind of the PGY-1 harmonized KGO as kind of the template, and then obviously elevated it to take into consideration kind of the elevated expectations that we'd want our PGY-2 residents to be able to do. Okay? The hope is that by creating kind of a harmonized template for PGY-2 residency programs, that as we go through the process of revising KGOs for all of the available PGY-2 programs out there, that it'll be a much more efficient process. And now there are obvious differences between the individual PGY-2 programs. Those specific details will be outlined and highlighted in kind of the appendix, and that's kind of the process that we'll be moving forward with. The KGOs have been approved. The PGY-2 direct patient care template for KGOs have been approved, and then the template that will be used for the appendices has also been kind of standardized across all of the different program types. Now that non-direct patient care PGY-2 residents is a different animal altogether. We've started having some conversation about whether or not we can actually create one single non-direct patient care template that would be applicable to all of the different types of non-direct patient care, residencies out there for PGY2, and if it's possible, we'll create one, but that's more to come. For the PGY2 Pediatric Pharmacy and Pediatric Specialty Pathway, KGOs, those programs, the PGY2 KGO was revised and approved in August regarding using the direct patient care template that we approved. And the expectation is that all of the programs that fall under that category would implement the new KGOs for those programs starting July of 2026. Multiple work groups are already in place for additional PGY2 direct patient care types of residencies as listed on the screen. The expectation is that as soon as possible, as the work groups kind of finalize their appendices and recommendations to the COC, that the COC will consider them and then implement them accordingly. We're really looking at kind of an 11-month window, is that 11 months or so after the template is approved, that'll be implemented into the field. So if you look at the bottom of this slide, if the KGOs come to the March COC meeting and they approve them for the work groups that are currently working on them, the expectation for the field is that for those work groups that get approved, they would expect the programs under those types of specialty areas to implement the KGOs at the start of the next academic year. Just going to highlight where we are with some of the newer programs that we've created. On the left-hand side of the screen really speaks to PGY2 thrombosis and hemostasis residencies that was created relatively recently. Today, we have 11 total programs, of which 8 are currently accredited, 2 are in candidate status, and then 1 is in pre-candidate status. As described in kind of ASHP documents, is that after these demonstration progress are in place for a couple of years, we'll go ahead and revisit whether or not that demonstration qualifier still applies, and we expect that to take place around 2028 for these types of residency programs. And on the right-hand side of this slide kind of speaks to the pediatric specialty pathways, and thus those are also starting to kind of grow and expand as well. For the critical care specialty pharmacy in pediatrics, we've increased from 6 in 2024 to 8, and then similarly we saw an increase for the oncology specialty pathway going from 4 to 6. And lastly, really because of some discussion that took place at the August COC meeting, where really it was geared towards what is the value of residency training, we formed a task force that includes multiple different types of stakeholders, members of the COC, members of the Accreditation Service Office, and partner organizations so that we can really get a diverse group of perspectives and input from a lot of different areas. And the hope is that we'll be able to create a value for the field that kind of highlights the value of residency training. That task force will be led by Katie. I mean, it's still just kind of getting started, but hopefully we'll hear more from that a year from now. All right. So with that, thank you for your time.
All right, well, thank you, John. And I get the pleasure of kind of talking through what has all happened that's not COC related, or some of it related to COC too, and then we'll get to the Q&A section. So this is the section called We Heard You. Last year at Midyear Town Hall, we took a lot of the feedback that we received the previous year, and we really looked at all the themes and really gave an update as to what had all happened and how we addressed and those kinds of things. So this year for the Midyear Town Hall, we looked at last year's feedback and we talked a lot about survey transformation and some of the plans that we had. And that was really the theme that we had from the Q&A session last year. So I am excited to be able to say, all right, I will give you an update as to where we're at for things like survey transformation and all of that great stuff. All right, last year at the Midyear Town Hall, we introduced the concept of survey transformation, and really just to kind of remind you what that looks like, it's the collective efforts of ASO and in partnership with the COC to really look at all of the components of the accreditation survey process from start to finish and really take a look at all of the materials that are being submitted and how things are looked at and all of those types of things, and identify opportunities to optimize the survey process, both for programs, but also for us in ASO to be able to create consistency and efficiency and all of that great stuff, all while retaining the really high quality outcome that we all expect of our residents in our residency programs. This also really aligned with ASO's purpose and the emphasis on collaboration with you as programs as it relates to how you're training residents and how we can continually improve and all of that stuff. So, as a reminder, this initiative really started around March of 2024. We had lots of listening sessions with you guys, and again, last year, the Midyear Town Hall gave us some great ideas, and we were implementing some things as soon as we could. But what really marked a great milestone for us is July 1st, 2025 this year. We were able to implement a lot of larger enhancements that I think people were really excited about as it related to the survey process, as it related to consistency, as it related to the packets that you turn in and all of those types of things. So to celebrate that, this is a really great, I think, pictorial of all of that and what has been implemented and what we are continuing to do as a continuous process. So as it relates to the survey process, simplified, streamlined, a lot less paperwork. For those of you that have been lucky enough to be surveyed since July 1st, 2025, I think, hope, and pretty sure that you have appreciated a very slimmed down pre-survey material packet. There's still materials that you submit in advance, but relative to maybe previous surveys, hopefully much more simplified, streamlined, and efficient from that standpoint. We also redesigned some of the materials as well. And really, if you were at the previous session with Farm Academic and kind of what we talked about last year, really taking a lot of steps to work towards maximizing the use of Farm Academic as the source of truth. So if things reside and live in Farm Academic, it's not something that has to be duplicated and resent for things like surveys and for survey responses and all of that, which has been a really great effort with our Farm Academic partners. Again, the emphasis on collaboration. The survey is very collaborative, being more consistent with the survey itineraries to what to expect for a survey, to be efficient with your time, and all of that in terms of a collaboration piece has been another thing that we have slowly started to implement, but really implemented July 1st of 2025 with those of you that were surveyed at that point. And then that's not the end of it. It's not like we finished the end and we're like, okay, we're here, we're done transforming the survey process, but it really is an ongoing improvement piece. And like Sam said, we're really looking for feedback from you and from folks that have gone through the survey process. We've heard really great feedback already, but we're continually making improvements because it's not like we've identified everything and have finished it. So we've got a lot of pieces that we're working on, pieces that we hear from you, looking at continuing to update our tools and our resources and continuing to make adjustments with our Farm Academic partners and feedback that we hear from you and other educational sessions and those kinds of things. So I'll try to summarize those in the next couple of slides and then open it up to the Q&A. So as it relates to this continuous process improvement in addition to the survey transformation and all of the cool stuff that goes along with that, we're really, again, our goal is to make adjustments that really streamline processes. They support reducing the administrative burden that we heard a lot from you in our previous town halls and other listening sessions, and really trying to make those improvements and make those adjustments. Also improvements in gaining and maintaining accreditation, so not just the process of the survey itself, but making adjustments to the annual reporting and trying to simplify that, making that a bit easier, quicker, streamlined to get the information from you to us on an annual basis. Looking to streamline the applications and the RPD change processes and lots of other things kind of going along the line. John mentioned a lot of things that the COC was or is looking at and has done in terms of the regulations, in terms of the standard, in terms of the KAGOs. One of the things that we are aiming to do is to look at that annually and make those adjustments annually as opposed to every single COC, because we heard from you that it's really hard sometimes to keep up with all of the changes and make sure that you're staying current and that type of thing. So if there is a significant need to make adjustments more often than annually, we will, but we're really trying to move that to an annual review, but also to really look at that. I think you noticed, or hopefully you noticed this year with the standard update, a lot of went into the guidance update was clarification and really trying to further be transparent about how something is surveyed, not changing how it's surveyed, but really provide the information to you as to how it's surveyed so that you've got that transparency. So really looking at that from an annual standpoint. So I think that'll be a great piece. Streamlining the KAGO revision process. John also talked about the work that the COC has been doing with that. We really heard you. I feel like when we started saying, hey, we're going to be doing the KAGO revision, I know at several town halls we heard, what's going to be the runway for implementation? We really need time to be able to implement when our KAGOs are updated. Is it going to be all the KAGOs at the same time or different specialties? And so as the COC has really worked on that, not only has the group worked to streamline the process like John had talked about, but also making sure that we give a long enough runway for programs to be able to implement when a new set of KAGOs is available from the COC. And then again, the enhancement supporting farm academic as the source of truth. If you were in the previous session, there were a lot of really exciting things that were talked about related to farm academic. I will try my best to summarize some of the great things that occurred with farm academic updates over this past year, and then looking ahead what we're looking to do. So I think the thing that is biggest on people's minds is the electronic resident development plan, which went into effect this year. Certainly lots of positive feedback. We've heard lots and lots of a good feedback related to that, something I think that people have been waiting for and you've been asking for and programs have been asking for. Certainly there has uncovered some enhancements that we would like to make now to make it even better, but those are some of our future adjustments. But overall, the implementation of the electronic resident development plan, honestly, I think has been a game changer as it relates to the development plan and understanding what goes into the development plan, how to do it, and to really make sure that the content is reflective of what the development plan is intended to be as that GPS for that individual resident that you have. Also enhancements to the electronic APR, which I think was very well received last year at Midyear Town Hall, and continuing to add adjustments and enhancements to things like the APR reviewer role, the APR review status, all of those kinds of things. And even the adjustment made to the APR last year when standard 4.6C, the preceptor qualifications piece, was eliminated from the standard, updating the electronic academic and professional record to make sure that those flags are removed now and it becomes an optional piece as opposed to a required piece. Lots of other enhancements throughout the year with farm academic as well. Evaluations got a little bit of a facelift in terms of the reminder scheduling and some enhancements with related to being able to save processes and things like that. A little bit of adjustments to the duty hours, to the response clarification to give a not applicable option for duty hours. Learning experiences just recently now has a selective option available as you're categorizing your learning experiences. I know there were some questions in the previous session related to exactly what does that mean, but that is also a great option when you've got a grouping of learning experiences that residents will select from that standpoint. And then of course updates to reports and usability and filtering and all of that great stuff that is really helpful for both program management and also, quite frankly, on our side from an ASO standpoint as it relates to surveys and things like that. So lots of accomplishments and more to come. So future plan enhancements with farm academic. If you were in the previous session, there was a screenshot of the homepage getting a redesign, and it's really being streamlined for global functionality. It looks really nice. It's coming in spring of 2026. The electronic development plan is the top of the list for future enhancements. Some things that we heard a lot were availability of the initial self-assessment when you're first starting your residence, so that is definitely something being worked on. Having the electronic resident development plan be available for PGY2 residents and PGY1-2 programs, so that was kind of a subset that kind of required 2 years to implement. And a number of other enhancements that I know I heard in the last session and different adjustments that we've been working through. So It's so great that there has been such a great uptick and a lot of great response to the electronic resident development plan, and just plans to continue to make it even more user-friendly for programs, for residents, for everybody involved. Some other future enhancements, a policy attestation is being worked on. So, you know, that part of the standard where you have to review the policies with all your residents and sign off and then kind of keep those copies somewhere or scan them or those kinds of things like that. So having an enhancement to be able to do that in Farm Academic, I think will make life easier as well. The required appendix, so John talked about our brand new PGY1 program of veterinary pharmacy, which I just want to revisit and say, oh my gosh, 1 year later and we have a whole new PGY1 program. That is amazing, so that is incredible. But with that, John talked about the appendix that went along with that, as well as the managed care. And if you're a PGY2 program, you're very familiar with the required disease state appendix. That is something that we know we want to look at and redesign and make more user-friendly in Farm Academic. So that is definitely something at the top of the list to take a look at. And with all of this movement towards using Farm Academic as the source of truth and the great response that we've gotten from the electronic development plan and from the electronic APR, eventually it is very set up nicely to be able to move that into something that is that we use Farm Academic for and try to get rid of some of the paper related to that. So the session before, and I'll just re-emphasize, all of these things in terms of the enhancements on the last slide and the future plan enhancements are related to feedback that we get from all of you. So thank you and keep it coming. There is a feedback form in the Help Center in Farm Academic. The last session had a QR code, so we can try to get that out to you as well. But that is really a great way to submit, hey, what about this? Is this a possible enhancement? And that's where we get all of these ideas from and different focus groups and things like that. So thank you in advance for everything that you're doing, not only to help us related to the survey transformation process and all these other improvements, but also being able to use Farm Academic as that source of truth in the easiest possible manner. Okay, another thing that I am really excited to talk about is the ASHP Residency database platform coming in 2026. I know, how excited are you? An update to the ASHP Residency directory. We are redesigning that. I feel like I should hear an audible like, oh my gosh, that's amazing, right? Yes! So it is totally being redesigned, and it relates to a lot of other enhancements, but I, as a former RPD, am really excited about this because I feel like the residency directory for your particular program, right now it's a little bit clunky, it's got a lot of text, it may not be used as optimally as it could be used and those kinds of things. So we're really looking to redesign that, and there's work already that has been done on that. But it'll be less text heavy. There'll be the ability to customize, at least for updating logos and those kinds of things like that. Enhanced searchability, we've heard a lot about, hey, it would be so nice if I could go into the residency directory and search different fields and things like that. So there's that function that'll be coming. Looking to highlight maybe, just as an example, for searchability, like programs that accept through the early commit or programs that are able to accept or sponsor visas or things like that. Just things that would be really great to be able to search through, and so that is coming. That'll help us kind of move towards enhanced automation for other components, but just wanted to let you know that it is coming. We will be very sensitive to when it is rolled out because we know we don't want to change the directory redesign in the middle of recruiting season. So some of that will come in the off season, but just a really exciting enhancement. And I am going to show you a sneak peek. This is not exactly what it's going to look like, but just to show you that work is being done on it. This is just a little bit of an example of what it may look like, and it's a very basic version. Don't pay attention to exactly what are in like the quick link buttons and things like that. I know you're looking at it and going, really, should the number of positions be the very first thing that you see or that type of thing? But the whole point is that it'll have some customizable features, it'll have some quick link buttons and some quick summary kinds of pieces to be able to really see important parts for residency programs and all of that great stuff. So, more to come on that. All right, other things that we have been working on throughout the year. Hopefully you've noticed some really great educational enhancements. that we had come out of ASO. We had an incredible response to a webinar that we did this past August called Talk Saves Lives, Suicide Awareness for Pharmacy Residency Programs. That was something that ASO partnered with the American Foundation for Suicide Prevention, and really just want to thank the foundation as well that really supported us from the Daniel M. ASHP Fund. But we did a live webinar in August. We had 561 attendees that individually registered, but we know that number was much more because we know that people listened in groups and things like that. If you missed it, there's a recording that's available. It's for free in the Learning Catalog and a number of other resources related to that. But that wasn't a one and done type thing. We continued our partnership with the American Foundation for Suicide Prevention and are creating a toolkit for residency programs and for residents with specific information geared towards residents. That first email went out in November, just before Thanksgiving, and really trying to be thoughtful about certain times of residencies that might have different things going on. And so this was kind of thinking about the holidays and those types of things, and providing some tips and links to resources for residents. We put a copy of that out there on RPD Connect too, because it really isn't just for residents. Anyone can benefit from these resources. So we put a copy of that out on RPD Connect and sent it out to residency program directors by email too. But just so you know, that was the first of a series of contacts that we'll have with residents related to that. We also had, for Ask the Surveyor open Q&A sessions, we held our first virtual Ask the Surveyor open Q&A session in September of 2025. A lot of really, really great participation with that, and so we plan to continue to have virtual Ask the Surveyor sessions in 2026. But don't miss out on the live sessions that are also held here at Midyear. There'll be 2 sessions on Tuesday, one between 10 and 11 and one between 2 and 3. So those are another opportunity to really get your questions answered. But it was nice to be able to offer that visual piece, or the virtual offering, so that people could participate from that way as well. All right, and then from a hot topic standpoint, Pharmacy Futures. The National Pharmacy Preceptors Conference was back live in person this year in 2025 as part of Pharmacy Futures. It happened in June in Charlotte, North Carolina. Again, it represented the return of NPPC back in person. Really, really awesome to be able to have that as a conference within a conference, right? Because if you're registered for NPPC or Pharmacy Futures, you participate in any of the sessions related to both Pharmacy Futures and to NPPC. We had almost 900 preceptors attend the conference, which was great. We had a lot of precepting topics. There's over 9 hours of preceptor-specific focused sessions of continuing education. Just as an overall standpoint, the Precepting Gems session that was there was the second most attended of the entire conference as it relates to Pharmacy Futures and to NPPC. So that was really, really exciting to see. So even more to come. So if you are really like, wow, that sounds amazing, how did I miss it in 2025? Don't worry, because 2026, it will be June 13th to 17th in St. Louis. So there'll be even more precepting sessions, networking, posters, all of that even specifically related to preceptors. Okay, and then the last, did you know, we do have a residency program director mentoring program. And that is something that Michelle McCarthy helps us with. The program began in 2022, and it really matches new residency program directors with seasoned residency program director mentors. So over the time since 2022 when the program began, it's matched 722 mentees with 484 mentees, and that is and counting. So if you're a new residency program director, typically you'll receive an email from Michelle in the fall to collect your interest in participating in the program. With that, there is a meet and greet that is happening tomorrow here at Midyear. So if you're a member of a mentor or a mentee in any of the cohorts, you are welcome to participate in the meet and greet, which is tomorrow from 4:30 to 5:30. All right, I'm going to finish this off and then we can turn it over to the Q&A with just the match timeline. All of this is on the match website, but just wanted to point out that, again, we've received a lot of really good feedback to have a little bit of extra time between phase 1 and phase 2. So that has been retained in the match schedule. And otherwise, the dates are there, but you can definitely refer to that on the match website. And with that, some pictures of our great COC group and our ASO staff and lead surveyors. With that, I'm going to turn it over to Sam to start the Q&A session. So thanks for your time, everyone, and I just really appreciate everything that everybody does for residency training. I think I speak on behalf of all of us to say thank you for all your feedback, for everything that you do. Fantastic.
So if you could bottle that energy, right? She's very. I always send her to tell the bad news because people thank her after they tell her bad news. All right, so my friends, we've made it to Q&A. So there are microphones set up in the room. Please approach the microphone if you wouldn't mind saying your name, where you're from, and what questions do you have. The panel is here. They all specialize in a certain area that can help answer those questions. Remember, if it's just feedback, we love that. I love town halls, and here's the thing about town halls. You can ask whatever you want. All questions are welcome. If I don't know the answer, I will get it to you. It may not be the answer you want, but it'll be the answer, right? So I promise to get that to you. Eric is going to be taking notes. If we have enough questions and we think there's substantial responses that people need to know, we'll publish it on our site so that whether you're here or not, you'll all have the same answers. So who's my first taker? Someone's coming to the mic. Hold on.
Hello. My name is Wendy. I'm from UF Health Spanish Plains Hospital in Florida. I'm kind of wondering if maybe in the future you would consider creating a registry of residents that have completed successful completion of residency, kind of like a board certification directory where you can look up to know, because we have had residents that have not completed our program, and when employment verification is coming and looking through, it looks like they've completed the program because time-wise they did, but it wasn't successful completion. So it's just a way to kind of have a national registry.
Yep. So good. So I will tell you that we do have a list of that internally. So usually, sometimes we'll get answers to questions to verify if someone completed a residency. Right now, it is sitting in the fabulous spreadsheet format that works oh so well. But we would love to put that into a system that folks can query it themselves. Here's the one thing that we know that we're concerned about is that it will always be maiden names. So if someone gets married, you might not be able to find them, but we'll worry about that when we get to it. But that database does exist. We just got to figure out how to operationalize it. And it could be part of this one part of our system. I'm looking at Amy, so she takes note of that. So what Julie showed you that she was very excited about, I forced her to do the screenshot. She's like, but what if it doesn't look that way? I said, I want to make sure people know it's real. And that, because how many times do you hear people, it's coming, don't worry about it, but it is real. And phase 2 of that is doing the survey process itself, where the surveyors are going to be able to use the system to have a standardized way of surveying, but then giving you a report. So I don't know if all of you know that they go back to the hotel till like 10 o'clock at night and write a report up. I don't know if you know that, but we need to give them some sleep sometimes. So that's phase 2, and that is, I promise guys, that's coming too. So this will be something we can add to that as well. Thank you for the suggestions, but we do have that database. And in the meantime, if anybody ever wants to ask those questions, all you have to do is send it to asd@ashp.org, and we can get that for you.
Hi, Sam.
Hello.
Allison Porter from Kansas City, Missouri. I have clarified this with Mitzi and Andrea, but I think it would be helpful to share with everyone here about the 5-day, I want to call it an expiration date. It's not an expiration date, but the 5-day turnaround on signing and co-signing evaluations, because we had a discrepancy and it came up during a survey that I did, and I think it would be helpful for everyone else to know that. To refresh your memory, it's not about when the evaluation fires, but when the rotation ends in Pharm Academic.
I'm looking at Andrea.
Yeah, I'm trying to remember our conversation, so can you refresh your memory?
Yes. The question came up whether or not your evaluations are considered overdue or late, within what time frame, and the way that you had clarified it to me was that it was within 5 days of the rotation ending, not necessarily 5 days from when the evaluation was completed.
So it's actually 7 days.
Or 7 days, I'm sorry, yes.
So per the standard for any summative evaluation or any preceptor, evaluation of the preceptor or evaluation of learning experience, the evaluation has to be submitted initially within 7 days of the due date to be considered on time. And again, this is an initial submission. If it's sent back for edit, it doesn't count against you.
What is the due date, though, in reference to? Are the 7 days, is it in reference to when, like, the resident completes it, or is it in reference to when
So the 7 days
rotation?
is in reference to the scheduled due date in Pharm Academic.
Okay.
And cosigns cosigns aren't really required, so there is no, deadlines or due dates related to cosigns.
Calendar days or working days? I've been asked by Jamie Sinclair, who's sitting over there, is that calendar days or working days?
Calendar days.
Thank you, Jamie from the Peanut Gallery.
Hi, I'm Christina Heimrel from the University of Wisconsin Health, and I have a question regarding, so we're doing our APR reviews, our electronic APR reviews right now, and at our organization we have over 200 preceptors, and many of them precept for both our PGY1 and our PGY2 programs. And I like that in Pharm Academic they enhanced where preceptors can select which programs they precept for, which is excellent. But what we're finding is we're having a hard time getting everyone to click those boxes. So is there any way that Pharm Academic can be enhanced so that when a preceptor submits their APR that it automatically is viewable to any program they're linked to?
I think we've talked about that, and we'll definitely talk about it more as a future enhancement.
Awesome, thanks.
Hey, Jeff Jolliffe, Kern Medical in Bakersfield. I'm kind of old, I guess. I just wanted to get a pulse check from the COC on kind of how you guys view ambulatory track PGY1s versus other track PGY1s. Once upon a time, we had other naming conventions. Now everything's PGY1 pharmacy residency. But I see there's like 150 ambulatory care track PGY1s, and I just wanted to see what you all thought of that.
John?
Personally, I don't like it because we have a PGY2 ambulatory care residency in our program, and it kind of distracts the candidate on whether or not they'll get the same level of experience in a PGY1 ambulatory care track residency versus a PGY2 residency. I mean, that's just my opinion.
I agree with you. Is it okay to do? I think that would help out. We have a PGY2 ambulatory care residency, and I feel like the last few years interest is decreasing because there are these PGY1 AM care tracks, and maybe they can land that job with that training without a PGY2. But I just kind of wanted to see if you guys thought it's taboo, or should I jump in the pool with the AM care track folks too and try to work that angle?
So, great question, great comments. To clarify things, there is not necessarily a PGY1 ambulatory care program type. So I know you mentioned it's a PGY1 pharmacy ambulatory track. To clarify, any of those tracks, so ambulatory, pediatrics, oncology, what have you, each of those tracks would be specific for electives only, because every resident in the same PGY1 program must have the exact same required structure. So what that means is the same required learning experiences of the same duration, the same cadence, the same completion requirements, all of that. So it can be a little bit confusing looking at different promotional material for different programs that are out there, because there are some naming conventions that are not supported by the regulations and the standard that are used out there that, you know, may advertise as a PGY1 ambulatory care program or a PGY1 ambulatory care focus program. So right now we just have the 4 PGY1 programs: PGY1 pharmacy, PGY1 community-based pharmacy, PGY1 managed care, and PGY1 veterinary pharmacy. Now there are different settings where those different programs can occur. So there can be a PGY1 pharmacy program in an ambulatory care setting. Same thing that we have with a PGY1 pharmacy residency program in a children's hospital, so in a pediatric setting. So it could be described as being a PGY1 pharmacy program in an ambulatory care setting. So it's all based on the setting and not necessarily a track specific to that, unless you're just referring to the electives, having an elective ambulatory care track, if that helps.
That was the question, if we could have different required, not rotations, that's a faux pas. I told you I was old. Learning experiences. Not, who wants to go back to rotations? I don't know. I still can't get that word out of my mouth. Don't say it, I'm sorry, Michelle.
You are fine.
But thank you, you answered my question.
Thank you.
Hello, Jamie Kiskin, Sarasota, Florida. I just had a question about, from the person before, asked about electronic APRs. And I think one thing we recognize in learning, and by the way, we love the enhancements you guys have done and being able to track that. That's definitely an improvement, so thank you. I was wondering though, because we have our team that's looking at all of our programs at the same time, and so now they have to go in and multiple times designate that somebody has, has met the criteria, or they have a ongoing performance or a plan to meet preceptor criteria. Is there a way to update Pharm Academic or maybe in the future enhancement so that when you do it in one, you have some ability to toggle to say that for all 3 programs or however many programs that preceptor is precepting, they meet criteria versus having to go switch out. It's a very manual process and may, again, lead to gaps if we don't have good kind of quality control over that. So just would love that ability to do that so it saves our team a little bit of time and more efficiency.
We have heard that, and it is on the list of looking at for a future enhancement.
And when we say on the list, it's this year coming up list, yes?
So,
You see, I'm on your side, guys.
so we came up with a 20. So
Yeah.
the list, as you know, so what we're looking at now as future enhancements would be accomplished during the 2026-2027 year, and I think the APRs were on it, but I don't know where they were as far as priorities.
Yeah. Yes. Huh?
Hi, so this kind of falls along the same lines of the previous request or question about the PGY1s. As specialty pharmacy residencies continue to expand an additional add-on each year, it seems like, is there going to be any separation at all for the objectives and requirements for those? Because right now they fit under community pharmacy, and a lot of students aren't aware that a lot of these community-based programs are actually specialty. So is there anything in the future that's going to show any separation between those, or any additional categories that could be added?
Okay. I think this is on, yes. Okay. Yeah, no, that is a great question, and also to take on to Jeff's question. So part of the excitement of the residency directory update is to be able to have some of that distinction and searchability and that type of thing. And I think that's really the way to address, like, hey, how can I find a PGY1 residency that's conducted in a specialty pharmacy space or things like that. And so from that standpoint, I think that's where some of the enhancements for the searchability will come in. I think that's the way to address it, as opposed to trying to create a whole bunch of new titles and things like that. So that is one of many reasons why we're excited about the directory update.
Okay,
But
thank you.
thanks for that.
Jessica Hinson, Ohio Northern University, new residency program director as of July. I really struggle because our program's weird, and I don't know how many weird programs there are. We are not hospital, we are not community, we are comprehensive clinical services out of a college of pharmacy, and it's a pretty large umbrella. So I've been around for 2 accreditation visits now, and there always is this push and pull. Are we general PGY1, which we're pretty clearly told is hospital, or are we community because there's a community pharmacy there? But as a graduate of a community program, it is not a community program. And like, I was really excited when the standards kind of aligned, hoping that would kind of help, but there was still a lot of confusion. So are we having discussions and working towards things for unique practice environments that necessarily don't fit into those boxes?
I can kind of address that too, but I'll call on friends to jump in. Also a really good question, when the standards were harmonized, that really related to all of the different program types falling under the same standard. But the PGY1 KGOs are also harmonized under the same set of competency areas, goals, and objectives. So I'm guessing maybe your question has to do with, what do we call ourselves, PGY1 pharmacy or PGY1 community-based pharmacy?
Kind of, and like where, again, what we think at our site was definitely different than what our surveyors thought.
Yeah.
So we just really struggle in the fact that we don't fit into these clear boxes.
Sure. I think and we can maybe have some offline conversation, but just to kind of circle back to your comment, PGY1 pharmacy doesn't necessarily mean that it has to be only in a hospital setting. PGY1 pharmacy is in lots of different types of settings. So from that standpoint, I think there's a way to address your issue, but just maybe knowing a little bit more about what your specific outcomes are, it would be helpful. But
Okay.
yeah.
Thank you.
Yeah, you're welcome.
Kirsten Oler, PGY1 Residency Director at University of Illinois, Chicago. First, I'd like to endorse that webinar about Talk Saves Lives was a very useful webinar, probably one of the best I've been to. I watched it with my residents, and it opened up a lot of discussion just within the group, so thank you for doing that. If you haven't seen it, I would strongly suggest it. First, I want to bring up again something that I've brought up several years now, is if we could think about standardizing PGY2 start dates, or at least making them not before the end of a PGY1. Once again, this past year, I had a resident who had to take vacation from their PGY1 program to start their PGY2 program, which causes problems in a lot of ways. And now apparently I have to put a stop date on the certificate, so I'm not sure if I put the date that they left the program or the date that they officially were supposed to end it. And then second, I would like to bring up again the discussion about extension versus assessment of competency for residents who aren't licensed within that deadline. As you may know, Illinois is notorious for having a bad MPJE. The last I heard, 40% pass rate on the first time. And so we many times, I had 6 residents this year that did not pass the first time, and I have resident again this year that needs an extension because of that, and quite frankly, MPJE versus NAPLEX and a PGY1 residency, whatever. But last year's resident had achieved every single objective and more before they had to have their program extended, yet we had to extend it for 2 weeks because
of Illinois' MPJE, and I would just hope that we could reopen that discussion about assessment of competency versus days present in a residency, because days present is not equal to competent.
So I'm going to address your last two, but then I want to go back to the first thing that you talked about, which was the webinar. So those two items, I actually remember you coming up and talking about these last year. I'm going to ask that we put this on a COC agenda, those two items, to talk about the end date. Let's get the COC to weigh in. And the second, we will talk, we almost talk about the 120 days every time. There is, I'll be honest with you, there is a lot of discussion about that because of ensuring that the resident has independent practice, right, and that they're licensed. So it doesn't mean we're not going to stop the conversation, and maybe there's some type of, I don't know, exception or something we could think about that can help solve some of these issues. So let's reopen it. We'll bring it back to the COC, those two items, and get back to you, and to everybody on that, if that's okay.
Yeah, I guess because our medical residency colleagues have different assessments of competency, and they don't necessarily extend residencies for leaves like this.
And that's a great point of maybe we could look at some other residency programs, see how they handle it. Because sometimes we get, we're pharmacists, we like to, check boxes and make sure everything's perfect. So let's look, we'll bring that back and look at it. But I want to revisit the webinar. I think that was something that was really important to me as we've lost some residents along the way. And if, I know we have it in our standard for to make sure that everyone addresses it. But if we could address it and someone sees that webinar, and by the way, ASHP made that open to everyone, members and non-members, and still open that way. So you do not have to be an ASHP member to get to that webinar. We thought it was that important. And it can't be just one time, right? We have to try to hit it at a time when someone really needs that email to say there's people out there that help you, and that's why we're continuing that process of sending that out. So please tell your residents, look for signs, show them these things that they can find some help somewhere, and let's not lose another resident. So thank you for the feedback.
Hello, Jennifer Schwach, PGY1 RPD at Johns Hopkins Hospital in Maryland. I am the PGY1 RPD of a large PGY1 program at a site that also has several PGY1 to combined residency programs. And right now, in Pharm Academic, I'm listed as the residency program director for the first years for all of those programs. However, I'm not part of the development of those programs, the resident development plans, or really the management of the program. Yet I have to co-sign all those evals, which is a big added burden to my workload. So I didn't know if there was any chance in the future that we could have the option of selecting who the RPD would be, whether it would be the PGY1 RPD or it would be that PGY2 RPD, so that sites could decide what was best for them.
Andrea, any thoughts on that? Or Andrea, in the works, or can we bring it back? Yeah, okay. We do not have that on the list, but we're going to take it back to talk to Pharm Academic about.
Hi, I'm Brandy Brown. I'm from TriHealth in Cincinnati, Ohio, and I'm a new RPD, so let me preface with saying that this might be a question that's already been addressed somewhere. Something that we're facing a lot is internal movement of our clinical pharmacists. So they're in one role and then they move to a new role. And so now they're technically not meeting the standard for precepting in that area, although it's a new clinical service and they're providing really good work in that area. So I guess, do you have any thoughts or guidance on how to make that work in your institution? Because another thing we're facing is lack of preceptors now. So just looking for guidance on how to handle that.
I can take a stab at that, and then we'll see if anyone else wants to chime in. Definitely understand your scenario with that. And in that case, particularly if you're talking about this is a new service and you're moving a pharmacist there so they can't have X amount of time in the service because it's brand new, right? What we want you to do is put the right people in the right learning experiences to precept. And if that means that it's going to take a little bit of time for that individual preceptor to be able to meet the qualifications and Really now when we're looking at qualifications, we're looking at time in practice of the area precepted and contributions to that practice. That's something that's taken into account from a collective whole when it's being surveyed. So from that standpoint, if all of your preceptors are in a situation like that, that would be something that would have a consideration on survey. But if you have one preceptor that you're putting them in the right place and that is the right thing to do, we wouldn't want you to not do that. But I'm going to defer to other folks to chime in if there's anything that I missed on that. I don't know if that helps address your question.
Yeah, like some of our pharmacists, they'll start out as, you know, clinical staff pharmacist, and then they'll move into some type of clinical specialist role.
Yes.
And a lot of that aligns with expanding our services. And so then it leaves gaps in multiple places. And so I'm just wanting to make sure that as this evolves, we're not missing the mark when it comes to accreditation, and that we're not getting cited years down the road now when this happens, I guess.
No, it's a good point. And what you're balancing is you want to make sure that your preceptor in that area has enough experience and expertise to precept a resident in that particular area. But when you're talking about shifting folks or people have taken on a different responsibility set and things like that, kind of looking at it like, hey, I used to meet all of these qualifications, but now I don't because I changed my practice setting. That's certainly something that we look at as a collective whole, but you want to do what's the right thing to have from a precepting standpoint for your residents.
So is there anything that we should be documenting, or like, I guess, how do you get ahead of that so then when survey time comes, you kind of have that backup?
Yeah, that's a good question. So if they are moving to a setting that now technically maybe they don't meet the time and practice in that particular area, then that's something that chances are that might be 4.6A. It might not, because if your preceptor is board certified, it doesn't matter. But if that's what they're using to meet 4.6A, then they would have a development plan that you'd have documented along with their appointment as a preceptor, and that's your kind of tracking for how they're going to meet that then.
Thank you.
You're welcome.
You know, I think that's a good example too of how, if you know who the lead surveyor was that was at your organization, to use them as, email them, what are the suggestions, how could, you know, they're here to help you. So part of that survey transformation is that collaborative piece, right? And that's where the collaboration begins. You have something going on, reach out to your lead surveyor and say, how should I handle this, or document it? Because the last thing we want you to do is to not train, right? We'll figure out how to make it work so that you can continue to train the best of the best for pharmacy. Yes, sir.
Hi, my name is Trevor, Residency Program Director at Munson Medical Center. It's in northern Michigan. To piggyback off that question, sort of similar, related to preceptor assignment. So we feel really good about our primary preceptor group. We try to schedule them with, you know, greater than 50% of the shifts with the resident rotation. But there are certain areas where we have lots of shifts that a resident might interact with, emergency department being one, where they start out on days, they move to afternoons after the first week. We have 24/7 coverage there, so there's potentially 3 pharmacists per day that resident might be interacting with, and then multiply that by the number of, you know, potential preceptors in that site. So they do have a primary preceptor that they are spending, you know, regular time with, but we struggle with who do we call a preceptor for residents to evaluate. And rotation to rotation, depending on how those pharmacists are rotating through those clinical areas and doing things like 7 on, 7 off, and how a resident rotation falls. A resident may, you know, one rotation have 7 or 8 days that they work with somebody, and then that, you know, in the next month, a resident might only have like 2 days with that same person, or you know, maybe even none. And so, but the way that's kind of in pharm academic is that person is assigned, you know, as a preceptor in the ER rotation, not as a primary preceptor, but as a preceptor for residents to evaluate, and that doesn't necessarily always, you know, make sense for some of those areas. So just from a survey perspective, for those kind of number of preceptors assigned outside of the primary preceptor, you know, what would you be looking for, and is there kind of rule of thumb of amount of time that somebody might spend with a resident where you would qualify them as one of those preceptors to put in Pharm Academic to be evaluated and have an APR and all that versus somebody who, you know, maybe doesn't have as regular. They could, you know, be in that role periodically, but you would maybe not put them in there as a preceptor, if that makes sense.
It makes total sense. Thank you for bringing that up too, because a couple thoughts come to mind as you're talking through that. You can change who the preceptors are based on the resident schedule. So when you build the learning experience and you have here are all the preceptors that they could work with, but then you actually have the resident who's going to be on that learning experience, and hey, they only worked one shift with this person or a couple of shifts with this other person or things like that. You can take those folks off of the entry that's on that resident's schedule. You can adjust that from there. You don't have to have every preceptor who might be on the learning experience on that particular resident schedule for that particular learning experience. So that kind of can help manage that. I feel like that's part of your question, but the other part is like, what's that threshold when I have to have them on there versus I don't have to have them on there? That's a little more challenging to kind of give you like a black and white answer. But from that standpoint, I would look at it, you know, it sounds like you've got a scenario where you've clearly identified who that primary preceptor is going to be and really kind of who that person who's owning the rotation is for that particular resident, who's going to be responsible for the Pharm Academic eval and, you know, kind of coordinating the activities on that rotation. From there, I would really look at it as who's spending sorry to say this word, a sufficient amount of time with the resident while they're on that rotation to determine if it raises to the level where they're really filling in for a day or two versus they're really kind of a primary part of that particular resident's rotation.
Okay, thank you.
I'm gonna just butt in right now because I would offer a thought on approaching this. The simple, much like I would clearly agree with Dr. Oler on the amount of time a resident does something doesn't give them competence. The amount of time that a preceptor spends with the resident doesn't mean they're going to give a competent evaluation. I'm sorry, but some of us suck at it. Some of us are wonderful at documenting in a timely manner and making an accreditation survey look good, but then it's too imprecise or it's not specific. I would actually suggest, not that I ever did it, but I haven't done it in a while, that you take the preceptor who writes the best evaluations. If they spent any time with them at all, you give them a couple hours one day to sit down and write the evaluation for that resident. Dedicated time to sit and tell some of the people that can't write a decent evaluation that they're just going to have to cover while that person is doing the right thing that you've been telling them for how many damn years to do. Start punishing people if they don't do it right instead of being nice to them. Now, I didn't mean to start with the rant, but you can see the rumors of my demise. I apologize to the commission, to Sam, to Lisa, shout out, the surveyors. Well, they're a little inaccurate.
I'd be disappointed if it didn't happen.
Well,
Frank.
it's going to happen someday. But I'm going to start with, I was going to say nice things, kind of. But one, I have seen for 2 years in a row now, 2 years in a row now, I have seen the commission in a temporally relevant manner address some of the things that are brought up. They may not be the biggest, but you're getting some things that are being done quickly. And I've been here too damn long. And it seemed like that didn't used to happen. Sam, I'm going to give you credit for. I'm sure it's not just you. I'm sure it's everybody.
It's the whole team. It's the whole team.
I'm a little nervous, and I'm asking a question in case you know now. Is this ballroom bigger than usual? Because there's too many damn empty seats.
There are a lot of empty seats.
I
feel like it's church because everyone's back there, and
but
the pews are up here. But
I'm going to yell at we should care about this and be willing to come in. Clearly, people are allowed to come in here and complain. There should be no reluctance to bring up a concern. It can be small, you act on it. It can be big, and you say, well, like for the past however damn many decades it's been to talk about the start date and competence. Well, you know what I'm going to say there, so I'll stop. But I do want to say one thing, and this is, I really respect the addressing the value of a residency. I think, and I just want you to do one thing. I want you to do a lot here, but I'm going to suggest one for sure, and then I have another potential thing for the solution you might have. But one, please don't be like the damn colleges of pharmacy and say, well, our student matched, so we are better than the other schools. Don't be the ones that don't have it just look at whether they got a job. That doesn't mean a damn thing. And in that regard, I've asked for before, I don't know if you're going to work on it or thought about, but there needs to be a survey of the employers. Were they ready for the job they were hired? Whether it's as a PGY2, who they get certainly damn early enough to have enough time to say whether they had to retrain them or not. And you're going to expect retraining is needed. But that's part, look at 5 years. Wait, you know what I want to do? I'm an old man whose time has probably come and gone, but I don't know how to stop coming. So if you want some passion and the thoughts of a person who just wants to argue all the time, which sometimes improves the outcome of a committee, I would be more than happy to be on that stupid task force. Because if you don't have people, I've done it for too damn long to not know what might be valuable. And if you trust everybody else, I'll live with that.
Yeah.
But I already put it out there, didn't I? So.
Well, I appreciate the feedback. I appreciate you volunteering. Maybe not call it a stupid task force, and maybe the chair would say yes to that. So, but the passion is what we need. Passion is what we need. That's how we know where to go. What's our North Star? How do we make things better for you? I'm not going to sugarcoat it. Being an RPD, being a preceptor is hard. It takes up a lot of your time. It does. So if there's things that we could do to get those obstacles out of the way so you can train the next generation and get to that point where you see your resident as a clinical specialist, a director of pharmacy, get the wins sooner, we're going to do that. So I welcome you, Frank. I was asking everybody, did anybody see Frank? Is he here? I need to make sure he gets the microphone at some point. So always come back, Frank. We love your passion. Yes, ma'am.
Hi, Jennifer Thackeray. I'm RPD of PEDS-ONC at Memorial Sloan Kettering Cancer Center in New York. I was wondering if the pediatric required topic appendix is going to be updated with the next oncology KGOs.
Who wants it?
I'll take this one too. That is a great question, and that is something that we need to really look at when we form the oncology KGO work group. Is because right now we're in a scenario where we have PGY2 oncology programs in pediatric settings with a special appendix for that. We now have the PGY2 pediatric specialty pathways, which didn't exist at the time that we created those PGY2 oncology appendices. And so that is something that we need to take a look at when we form that work group, which hasn't started yet. But when it comes time to revise the KGOs for PGY2 oncology, that is like at the top of the list of things that we need to consider is how to address that.
I'm happy to help on that whenever you're ready.
Thank you.
Gina Sable, new program director at Memorial Hospital in Ohio. Just a question. I currently have 2 preceptors who are pregnant and are going to be going on maternity leave. And they are currently the only primary preceptor on the rotations that they take care of. So just wondering the best way to approach that. So when they're gone for their 3 months, should I assign like a secondary preceptor to help them cover? Do I remove the primary preceptor just to make sure evaluations and everything still get done appropriately?
It sounds like you might be asking logistically, how do you manage it in pharma academic? Is that the question?
Yes, and more so just as what most people, I guess, would do is assign a secondary preceptor to that rotation to cover during those 3 months so that the resident still has a go-to person for that elective, even though maybe they might not be as specialized in that particular area, but I'm kind of stuck without a choice if the primary preceptor is gone.
Right. Yeah, a couple of things, and I'll let folks jump into. I'm sure you've probably looked at this, but kind of thinking about the cadence, if it's unavoidable to have the resident do that rotation during the time that the preceptors are on leave, then I think your solution of looking at who's going to be covering the patients at that time is an appropriate person to work with the resident while they're on that particular rotation. And then you can make that adjustment in pharmacoeconomic to reflect who is going to be there taking care of the patients and working with the resident. And that makes sense from that standpoint. I don't know if anyone else has any other thoughts that they want to jump in.
I think I was going to say the same thing, see if you can change around when the rotations are. But it seems like with 2 people out, your selection is pretty limited, right?
They're both two of our longitudinal, required over the year. So fortunately, they'll be later in the year, so they've already been trained initially, but there will be a 3-month time period where they have to be without their primary preceptor. Thank you.
Hi, I'm Carrie Dunchfield. I'm from Washington, D.C. PGY2 RPD new, but some history as a PGY1 director. I'd like to thank Frank for encouraging me to come up and complain. So you would ask what is challenging us to be able to get competent pharmacists at the end of the year, and I think one of the major things that I've seen over the last 5 years is a delay in licensure and having to have residents leave the program because they're unable to get licensed within the 120 days. And so I'm curious if this is more of a local issue or if you are seeing this nationally. And if you are seeing it nationally, maybe we could make a stupid task force to try to figure out how we can either encourage the recent graduates to improve the speed at which they're getting licensed or encourage the College of Pharmacies to move through those transcripts more quickly.
Yeah. So we are seeing it more national. It's not, it's not local. It is something that is why we partnered with the University of Georgia and we got some dollars from the foundation to do more research. So that research is ongoing right now to pinpoint the reasons why. Because when you let us know that a resident didn't make it through the program, you tell us that there was a licensing issue, right? But we don't know the details of that. Was it NAPLEX? Was it law? Was it they didn't get their information in time to get their attestation? So we're trying to figure that out so that we can give you better tools to make sure your residents stay in their programs and that you're able to get them through without an extension that a lot of programs can't do because it mucks with your FTEs and your budget. So we hear you. We're working on it, and as you heard, we're going to talk a little bit more with the COC about that 120 days and what we could offer as alternatives.
Thank you.
You're welcome.
Hi, Courtney Takis, St. Peter's Hospital, Albany, New York. I wanted to just add some comments to the previous comments about preceptor qualification. So this is something we're also struggling with, where I feel like we have great pharmacists who would be excellent preceptors, but based on the qualifications, they're not eligible. And one example I have is a pharmacist who's PGY2 trained, but because he doesn't have a certificate or board certification, he needs 2 additional years of practice before he would be qualified to be a preceptor. Whereas I have a PGY1 trained pharmacist with 1 year of experience, and she did a certificate. She's eligible and qualified, but this other more advanced training pharmacist is not. And so this is a challenge that we have, where we have several good pharmacists that either have to spend money that we don't have budgets for to reimburse, so they have to spend their own money, or we have to limit if they do a certificate versus board certification, or they can't get reimbursed until they pass. So there's just a lot of these other factors in play that are preventing some good pharmacists from contributing to the program, which is secondarily leading to burnout in some of our other preceptors who really could use a break. So I just wanted to throw out some of those thoughts as well. Thank you.
So I do appreciate those comments. I'll see if anybody has anything to say. I will tell you that we really value board certification. We feel that it is an appropriate credential to have, especially if you're the RPT for a specialty program that has a BPS available, a board certification available. So, I don't know if that would change, but right now I think the commission we believe that that is an important factor for RPDs to have under their belt if they're going to lead one of the specialty programs. Any other comments from?
Yeah, I'll just add too, from a preceptor qualification standpoint, it sounds like you're talking about 4.6A and really looking solely to use time and practice in order to meet 4.6A. And there's a lot of options to be able to meet 4.6A that is not just amount of time and practice. So maybe that's something, you know, and board certification is one of those routes. Other certifications is another route. Credentialing and privileging at your organization is a route. There's a lot of different options in there, so there might be something that can fit that particular individual that maybe is just kind of holding out for years in practice, if that makes sense.
Just to give one example of where like some of the requirement doesn't make sense, I'm a pediatric ambulatory pharmacist, so like if we started an ambulatory care program, I could never qualify to be the RPD because I practice in peds. I'm not going to get BCACP, but I'm 100% ambulatory. So just a small example of where it doesn't always make sense. Other than that, my name's Emily. I'm a PGY1 community RPD at University of Chicago. I'm going to throw you guys 2 really easy suggestions, and I have 1 question. Pharm academic suggestions, the new e-development plan, the due date for the residents and the RPD is the same day. So lesson learned during our first submission, if we had the ability to customize our residents' due date, because currently I have to give them a deadline, you know, outside of pharm academic and hope they meet it. So if we had the ability to say, I want it done 5 days before, 7 days before, that would be awesome. And the other, the other one came up during our last session, and there wasn't really a great answer, and it's regarding terminating your residents. And it's a very manual process, like deleting every rotation, deleting all the evaluations. If we had a functionality where you just say this resident is terminated and pharm academic automatically takes all that out, that would be awesome. I mean, hopefully we don't need to use it too much, but.
I actually wrote that down, like terminate, leave. I had that, I thought that was ridiculous.
Oh, it took me a half an hour, yeah.
We'll add that to the list of things to look at, for sure.
And then my question is related to the new e-APRs. Since the whole 3rd section is now optional, is there discussion of just, like, I can't imagine any of us are doing that work and keeping track of it if we don't have to for accreditation. Is there talk of removing that so that we don't have to keep reminding our preceptors, oh, you don't have to fill that section out?
Maybe I can chime in on that. For your question related to that, we did leave it in because there's a number of programs that still maintained some version of 4.6C as part of their internal requirements to be a preceptor. But what has changed with that is to make it not flag anymore and like, oh, you didn't complete it or now this is overdue from that standpoint. So we hesitated to remove it completely because there are still a fair number of programs that are using that or some variation from an internal criteria standpoint. I also want to address your electronic development plan suggestion in terms of the due date for the resident and the preceptor. And very good point, well taken. The other piece of it to think about though is that the due date for the electronic development plan, I think like the very first comment here was talking about when is something actually considered late for evaluations, and that 7-day. For the development plan, it's 30 days?
It's 30 days?
So just for any of you who don't know that, so the due date for the initial development plan is 30 days from the beginning of the residency. Updates to the development plan, expire every 90 days is the due date. For the updates to the development plan, you have 30 days after that due date to complete it, and it still is considered timely.
Okay, didn't know that. That's good to know. I feel like the other thing that got confusing with the due dates this year was that we thought it was gonna fire every 30 days from the date we submitted our first, we did the first one, and then it ended up being or every 90 days from the start date of the residency, which means your first one is actually really fast in the year. So it's supposed to be from the start?
So yeah, it's you have your initial plan that's due within 30 days of the start date. but then all the other plans fire every 90 days just to keep you on track of having one that you complete every quarter, even though I know that the time between the initial and the first update is sort of short.
It would be really nice if they were just all there. Like, I know they said next year the first one's gonna be firing 60 days before the residents, like the due date, to give them more time to do their initial one. It would be great if they were all there so we could see the due dates at the beginning of the year so we could plan for like our quarterly RAC meetings and when do we wanna do them in relation to the development plan. And then one more comment on the APR. I really like that you guys are trying to get anything that we need for accreditation and you need to look at into Pharm Academic. So I would again advocate for removing something because if they internally want to do more, that's fine. But like for accreditation standards, I would love it if Pharm Academic matched the accreditation standard. But thank you, those were all very helpful.
Thank you. Thanks for all the feedback, appreciate it. Yes.
Hi, I'm Callie, PGY1 RPD at Cedars-Sinai in Los Angeles. I was wondering if in the future we could get a little bit more of a breakdown of match statistics. I think I see trends in areas or with practice settings, but that would potentially help us with changing recruitment tactics or deciding how many residents in different settings if budget becomes a question.
Yep, so if you go to the NMS match website and you click into the year, you can go drill down.
Yeah, it's still not what I want. I was thinking maybe regionally, or perhaps if there is an ambulatory care setting or an inpatient setting, because I think I see trends in my little area, but I don't have actual data. So something like that might help us with planning purposes.
Well, I'm gonna have to take that one back, because I'd have to figure out how we would manipulate the data that's out there already. So I'll take it back.
Thank you.
Eric's got it. Thank you.
My name's Jenny. I am a RPD in Utah. I was just curious, I know we talk a lot about resident burnout, but what things do you have in place for RPD burnout and all of the many things that we're required to do?
So the webinars that we talked about, they're not specific to just residents. So RPDs can learn from those webinars as well. The other thing is everything that we're doing to remove burden, to clarify things, all of those are put in place to try to eliminate the burden, the stress that you feel as being an RPD and preceptor. So all the work that we do, what we get from here, what we've done over the last year is to keep you in mind on how do we make sure that you can do your job without all of the administrative burden or things that just drag you down. So that is, from my perspective, what we're doing at ASO and ASHP to support you as RPDs and preceptors.
Just curious, have you ever done a study to see how much protected time most RPDs have for residency-related duties in addition to their usual jobs?
And we have not, and we do have some language within the standard for RPDs, and ASHP won't be dictating to organizations on how many hours they should be putting into X, Y, or Z. That's not our role. Our role is more to make sure the standards are there for excellent training in an environment, and we don't kind of dictate to the sites how many hours they need to dedicate to training.
Thank you.
I'll just add to that comment that I just got surveyed back in January, and I did get asked the question of how many am I getting the 4 hours per week dedicated time. That question wasn't asked of me privately. I would recommend you ask that to the RPD privately in the future.
Good suggestion. Thank you.
Please. My name is Katie. I am a PGY1 RPD at Moffitt Cancer Center in Tampa, Florida. I would like to just discuss my love-hate relationship with longitudinal learning experiences. I also like rotations. Longitudinal learning experiences, I feel like, my surveyor, everybody loves longitudinal. Throw everything in a longitudinal. It's very difficult to throw everything in a longitudinal and then have someone serve as a primary to basically do 52 weeks, 48 weeks if you do it after orientation, of just managing something for a learning experience. Our teaching and education learning experience, our residents give 4 CE presentations, 4 journal clubs, they precept. There's a lot of different moving pieces that fall within that umbrella. And so what I find myself having to do is create custom evaluations to send to individual component preceptors of this massive umbrella learning experience, and have no way to feed those little custom evaluations to feed into the actual learning experience so that the person who's kind of the overall soothsayer of everything can have everything in one place. I don't have a way to pull in the objectives into a custom eval. I have to literally copy and paste them in and build the radio buttons myself. And I feel like, you know, that's teaching and education. If you move to like a leadership longitudinal learning experience, which was the one big thing that my survey pointed out to me, was that we needed to switch from having it be a concentrated to a longitudinal. But the leadership personnel that would be responsible for taking care of that resident do not have their hands on everything that the resident's doing for that learning experience. And how can I expect them to be on time to fill out these evaluations when they're really not in the know of these things? So I wish there was a way to have some sort of functionality built so that it could be easier to have longitudinal learning experiences within pharm academics. So if you could just take that to your little drawing board of trying to figure out how to do it, because it is a real struggle, and I would say that our evaluations are done on time for our concentrated learning experiences very routinely. I cannot get my longitudinals done on time to save my life. I've got a research project, an MUE, all of these fit into the same experience. I had them as separate experiences. I was told to put them in one, so it's like, we need some help on that. I don't know if I'm alone in that or if anybody else is having any problems with it, but I feel like it's really tough to kind of manage a longitudinal learning experience for a residency program. Any thoughts on that? Any guidance?
I have a lot of thoughts. Longitudinal experiences. Anyone want to address that from the surveyor standpoint? It looks like Lisa's grabbing the mic, so.
I certainly can appreciate what you're saying, and I think there's a lot of creativity. And I think when surveyors come in, they assess your situation and look at it and try to provide what their snapshot is of the day or your packet, and what they see in talking to different preceptors and the like. This is not answering your question completely, but providing some insight as well. If you feel that it's easier for you to have different experiences, for example, say for an MUE or something like that, and that's not a longitudinal, that can go into something else. You know, so you don't necessarily have to have 5 longitudinals. I just want to bring the point to you, or home to many, that these are ideas. These are different things that you can do. So if in your situation, if it's easier for you to have different learning experiences instead, maybe a medication use rotation. I find, from my perspective, but your practice management person is different. For me, I do recommend longitudinal. I will admit that, because there's different things that happen at different times of the year. So it's such a great opportunity for a resident to see budget time, to see if Joint Commission is coming, and to me that would be wonderful. So again, you know, most of us say in a residency survey, if you've seen one, you've seen one, and yours is one. So to meet that standard, do the best thing that's for you to meet all those objectives, to get everything in, and that facilitates a good residency year for you and your preceptors and the resident.
I hear what you're saying with respect to the standard, but I'm more so coming from the perspective of like actually getting our feedback to our residents in a timely fashion and like doing right by them. Similarly, doing right by the preceptors. And again, you know, having all of these different experiences split up into different learning experience means I'll have 5 evaluations that the resident has to fill out instead of 1 evaluation for the resident to fill out. If they're doing a journal club, a CE presentation, precepting, and it's all within the teaching and education domain, why couldn't that be something that they have to fill out themselves, you know, as 1 learning or 1 evaluation?
You can.
You know what I mean?
You can put that into an education rotation, and that's what I'm saying from the creativity standpoint. That doesn't have to be a longitudinal. That can be 1 rotation or 1 learning experience. Who said they were old? No, but that can be one learning experience. It doesn't have to be, and that's what I'm saying. If that works better for you, then that can be that.
Yeah, I guess my takeaway then would just be if you could create a way in Pharm Academic for us to pull objectives into custom evaluations, and somehow then those objectives could be then visible to a longitudinal preceptor when they're filling out their quarterly evaluation. I think that would be very helpful for us to facilitate that for our residents. Thank you.
Thank you. I was just addressing the other aspect, but those are all good ideas. We have better people to address the Pharm Academic aspect. So thank you.
Hi, my name is,
You're good,
wow,
you're good.
okay. My name is Kylie Kelly. I'm a preceptor at Purdue Veterinary Hospital, so yay for veterinary pharmacy.
Yay.
Yeah. So my two questions, again, being very new to ASHP, so I'm curious. So I think our program, like we've applied for candidate status. So if we are under candidate status and we have, a resident with us, are they, if she's interested in doing like a PGY2, like an infectious disease as an example, is that something that she could apply for while we're, kind of going through this process of accreditation? And then my second question is if we have a resident that leaves, partway through our program due to medical personal reasons, what does that process look like if they want to come back with us next year? Because sure, maybe our, hospital is like, yeah, for sure, we'll save the money in the spot, but with ASHP, what would need to take place for that?
So to answer your first question, for PGY2 eligibility, any resident who is in a candidate status or an accredited PGY1 program type, any of the 4 program types would be eligible for a PGY2 program. Now, eligibility and whether they're best prepared or best equipped for that PGY2 is a different story, but from a regulation standpoint, yes, they would be eligible. With regards to your second question, and I am blanking. Oh, the holding the position. So if you have dismissed the resident because they've exceeded the amount of extended leave that they are able to take within your organization, within your residency program, once they are fully dismissed from the residency program, if they wish to be part of that residency program again, if you wish to have them as a resident again, they would have to go through the application and the match process again. Once a resident is dismissed from a residency program, it would be a violation of the match rules and the regulations and the standards related to accredited residency programs to bypass the match to fill that.
Okay, thank you so much.
Me again, hello. In Pharm Academic, it would be nice if there was a tab that was visible only to the RPDs of the program where you could upload files that were only visible to you for record-keeping purposes. For example, like if you had to do a performance improvement plan or like a disciplinary, documentation, that kind of needs to go and be attached to the person or the program. So in case like down the road, like if another RPD came along, next year, they would have access to those files, maybe for accreditation purposes, down the road, or even stuff like the signed residency agreement, or the handbook signing, stuff that or even RAC meeting minutes that you don't necessarily want other people, other preceptors or other residents to see, but you want it to kind of stay with your files. It would be a nice have.
No, I appreciate that. I mean, we keep continuing to talk about how many folders and what can we add to there to make that one-stop shop. I will say we have to just be careful that we don't cross over into HR world. So we don't want to put files into a system that is not consistent with your HR and how they would want items. So, we'll be careful of that piece, but the other pieces you're talking about, if attestations for policies, things like that, we want to build within Pharm Academic. I'm sorry, Julie, I cut you off.
No, that's exactly right. I was just going to say, I love that you want to use Pharm Academic for a lot of things, and taking some of these ideas, I think to Sam's point, there are certain pieces that may not be able to go into farm academic, but the generating of ideas of other things that can go into farm academic is great. And also too, just for the group, really appreciate all of these farm academic suggestions. And just remember too that if you don't remember them right now, there is a way that you can submit them through farm academic, and that also helps kind of tally like how many people have submitted a similar suggestion, and helps to be able to kind of sort of prioritize certain suggestions and things like that. So keep that in mind too for once we're done at Town Hall to be able to provide that for additional suggestions that you have. So thank you.
I'm actually really happy with Farm Academic. With the documentation pieces, you know, of things that I've had to upload, and being able to run the reports that I can, it saved me from a lot of legal issues because all of it was in there. It's timestamped and documented, so that was like a huge savior for me. So
Great.
it's just another good thing.
Thank you. Thank you for the feedback. Marjorie.
Marjorie Shaw Phillips, former commission member, and not a question, but just replying to the call for help from the other RPD about wanting to get feedback to residents about longitudinal activities and be able to do a summative evaluation that makes sense. Just a plug that I've used many times for the feedback button. It's called formative feedback, right? And the best thing to do with longitudinal things that happen sporadically, or there's an assignment, or and we do this for our teaching things as well. Have whatever the evaluation the preceptor is giving of that teaching activity or the attending a meeting and participating, uploaded as formative feedback. That feedback button automatically gets sent to the resident, signed off, and it's something that the primary preceptor at the quarterly evaluation or at the end of the year, whenever they're doing that evaluation, could pull up all that formative feedback and incorporate that in the summative evaluation as well.
Thanks, Marjorie.
Thanks, Marjorie.
Hi, my name is Edna. I'm the PGY2 RPD at Stanford. I know we're running short on time, but just 2 quick questions. But first of all, I just wanted to thank you guys for everything that you do in supporting of the residency program, so really appreciate that. My first question is regarding presentations. So as you know, residents do a lot of like journal clubs and in-services and like more formal presentations and continuing education. So I was wondering, from an accreditation standpoint, how important is like documentation on feedback and also like attendance? Because I think a lot of these are just like Outlook invites, and if you look at it, it looks like no one attended. And then there's like a lot of good questions asked, so just wondering for accreditation, like what should I be documenting?
So documenting and going to journal club.
So I think Marjorie's suggestion was, or Marjorie's comments on using the formative feedback button were great, because that's a tool I think that's underused in programs. Regarding, I think you were talking about, I couldn't quite hear some of your answer though, so can you kind of ask me the second question again, or the?
So just for presentations, I have records of all of the deliverables, but then in terms of like preceptor attendance and like questions and interactions and everything that was asked, does that need to be documented?
No, you don't.
Okay.
You, as far as a survey standpoint, we don't look for that documentation. You can keep that documentation, but it's not a requirement of the standard.
Okay, thank you. My second question is, I was wondering if you have input on how I can support like the preceptors. So I think from a management standpoint, it's hard to like allocate like staffing resources to precepting. And I've seen a lot of preceptors invest a lot of time like just out of like professional interest, and then they burn out and then they go to industry. So just wondering like if you have like input on that. So I've tried to collect metrics to demonstrate to leadership, but any other input?
Any suggestions on preceptor time? Have you seen anything while you're in surveys?
I think there's a couple options, sort of depending on your specific situation, but maybe just in general, and I'll kind of take on to the point that Sam made. I think a lot of the efforts that we're trying to do in a global sense to try to reduce some of the burden also applies to preceptors as well. But in terms of specific examples for like a scenario that you might have, there could be things like, hey, what about thinking about doing a team-based evaluation here instead of an individual? Or, there might be a lot of ideas that we might need to know just a little bit more about your specific situation. But I'm happy to chat about that at some point as well. So just kind of thinking globally versus kind of specifically too. I don't know if that helps, but
It's helpful. Thank you.
All right, last question for today.
No pressure. I've got to make it a good one. Jeff Jolliffe, Kern, to Audrey's point, we love the feedback button. We probably use it too much. So it makes it hard for the person filling out the evaluation to know, in a lot of programs, maybe if they don't have a lot of feedback, you just look through the last 3 or 4 feedbacks and see if it related to your rotation. But since we always map it to that rotation, could we then take that mapping and put it back to the preceptor's evaluation so they see it when they're filling it out? I don't know what kind of lift that would be, but it would be very helpful.
Thank you. We're going to take that suggestion back. Much appreciate it. So thank you guys for sticking with us for the 2 hours. We really, again, appreciate your feedback. Keep it coming. It's not over. Use our email addresses. Send us things that, if you think about something that could be in a folder or make your life easier, send it to us. And just a big thank you for all that you do to train the next generation of pharmacists. We really do appreciate it. Have a great rest of the conference.